My name is Anat Loewenstein, and I'm heading the Retina at the Department of Ophthalmology in the Tel Aviv Medical Center and Vice President of the hospital. Welcome to this episode of New Retina Radio. I've got three distinguished guests with me today. Professor Daniel Ting from Singapore National Eye Center and Duke Medical School. Hi, Daniel.
Hi, everyone.
We've got Professor Patricio Schlottmann from the Medical Research Organization in Buenos Aires.
Hi, Anat. Pleasure to be here.
And we have with us Professor Paulo Stanga from the Retina Clinic in London.
Hello, Anat. It's a privilege to join you today.
Thank you. So let us go into our discussion about referring geographic atrophy patients to the retina specialty. Professor Stanga, why are we targeting the complement system when we are trying to manage our patients with geographic atrophy? What's the pathophysiological mechanism that directs us to do it?
There is significant interest at the moment in controlling inflammation and the complement cascade. We know that there could be a benefit in controlling inflammation and the complement cascade, regulating the complement cascade or modulating it in not only in ophthalmology but in various systemic diseases. And the challenge is to know at what stage, at what height of the complement cascade we should be intervening. CQ1 inhibition, C3, C5, MAC. So there are various clinical trials addressing all of these various and other stages of the complement cascade. We have significant evidence by now and two therapies already approved that target the complement cascade, two approved drugs, one that targets C3, another one that targets C5, and they both show similar results in slowing down the progression of geographic atrophy. So this is a significant achievement and a good extra weapon to our armamentarium in our fight against geographic atrophy.
I agree with you, Paulo. I think that at first also to me, the use of complement inhibitors to manage geographic atrophy was not intuitive, and I could not really understand the reason for targeting it. But evidence comes up that there are a lot of the complement pathway is really important in creating MAC that is detrimental to photoreceptor cells, and therefore the inhibition of this cascade has the potential benefit for our patients. In addition, we already have the data from trials that inhibiting the complement cascade is doing a difference in the management of our patients. Professor Schlottmann, do you have any insights as to where in the complement cascade would it be more beneficial to do the blocking, or just the mere blockade in this cascade is important?
Well, we know that the alternative pathway is the one that is, when it's modulated, is the one that brings the best results. We have had research in the past looking into, for example, factor D that yielded negative results. As it was mentioned before, blocking C3 or C5 gave positive results, and those are the drugs that we have these days. But I mean, the proof of the pudding is actually having phase 3 results that are, visible in large populations of patients where we can control geographic atrophy. I mean, a lot of the things that happen in the lab, so many times, sections of the very complex cascade have been blocked, and there are expansions and compensations of this cascade that ended up yielding no results whatsoever. So there's a lot extra to be done, but clearly we are in the right area of where we can or where we should block to obtain the best results. There's a lot more to come in the future, but it's only what we see in the phase 3 trials that matters to our patients. Whatever we see in the lab should only be a sort of hypothesis generation to go further into phase 1, 2, and 3.
I think like you that we already have results that blocking complement factor 3 is beneficial, and we've seen this in the Oaks and Derby trial for pegcetacoplan, and blocking C5 has been shown as beneficial in the Gather trials with Erver, and I think it's a lot of important information that we already have that blocking this pathway brings along results. we can say that the results are not as good as we wanted them to be, but we definitely see that the disease is progressing in a slower pace upon the use of complement inhibitors in these 2 points of the complement cascade. There are other potential drugs that are looking into other areas in the complement cascade, starting with the blockage of C1q, which starts the complement pathway, even though recently the phase 3 trials did not show a significant success, and ongoing trials that are looking at the end of the complement cascade inhibiting MAC. So altogether, there is a plethora of evidence already that blocking the complement cascade is important in the management of patients with geographic atrophy. Dr. Ting, do you have any insights on which part of the complement cascade is most important to block, or just the mere blockade has been shown good enough as giving results in our patients?
Personally, I must, declare that I am not, focusing my research in this area. But based on what I could actually already tell from the literature, I think the C3, C5 has so far been actually proven to be the relatively the more effective ones. Of course, the one is actually coming in the pipeline, as we mentioned before. I think one of the other thing, just in addition to the complement pathway, how do we actually deliver them? I mean, could we actually push for sustained release because of the treatment burden that we can already see? Money injections for life is just simply not sustainable in my mind. So maybe we would actually need to actually look into maybe the oral forms, or like the sustained release form is something that I hope to see coming out from a pipeline as well.
Thanks for listening. We'll be back in a moment. I think what Professor Ting, you mentioned now is really important, because for treatment that will need to go along for a long time without the patient experiencing improvement in vision, a slow release device could be extremely beneficial. So I think the point is very valid. What do you think, Professor Stanga?
Absolutely. It's a huge burden, not only for the patient and the national health systems in the various countries, but also for the relatives of the patient, because we have to remember that these patients tend to come accompanied to the clinic, and it's at the moment every other month injections for the rest of their lives. So certainly some slow release mechanism or devices that allow this, or gene therapy, as we are looking at the moment, could certainly be of benefit.
Professor Schlottmann, do you think that the use of either avacincaptad pegol, Izervay, or pegcetacoplan, Syfovre is a treatment that the patients will be able to continue for a long time as needed in this disease?
That's a very good point. We have to bear in mind that the average age of these patients is about 85 years of age. Life expectancy is constantly extending. But when we say for the rest of your life to some of these patients, we need to exercise some caution. Normally what I say to them is, this is a treatment that we may have until we have something better for you. So we don't sort of put them in the, this is going to be like a for life treatment. We know that it's a chronic condition, progressive condition, and we're going to be fighting the battle every month or every 2 months according to what we decide how to treat the patient. But we need to keep the hope that maybe in the future we will have something nearby, not too far away in the future, to provide extra treatment for them, something that is more amenable to their quality of life.
Yes, I think that a very important point is setting the expectations up front. And when I recommend treatment with complement inhibitors, which in my country can be given as under special permissions at this point, and we're expecting approval, I tell the patients, your vision will not improve. the disease will continue to progress. However, it will progress in a slower pace. And for this, you'll need to pay a high price, not in money, because I expect some insurance to pay for them, but a price of having an injection every month, 6 weeks, or 2 months for the rest of your life. And I think if I set the expectation in such a structured manner, I think this is why the patients, and I have had good experience in the patients that I'm treating, that they are not stopping the treatment.
That's the end of part 1 of this 2-part discussion with Drs. Loewenstein, Schlottmann, Ting, and Stanga. Stay glued to your podcast feed for part 2.